Hi, I'm Sandy Werner from MetroHealth. I'm the Ultrasound Fellowship Director, and welcome to this week's edition of Ultrasound Lecture Series. We had a great musculoskeletal lecture by Ben Boswell last week, and I am going to delve a little bit more deeply into the skeletal part. So we're actually going to spend some time on ultrasound of bone today. And I'll tell you, when I gave this lecture the first time, people gave me more than one fisheye. So, but that was a number of years ago. And now people are actually doing more ultrasound of bone, and it has some pretty high utility. So, of course, I have no conflicts to disclose. No one is funding me to do much of anything. So the technique and appearance of normal bone. We'll start with that. Oh, and I wanted to ask you, if you have any trouble hearing me, please let Matt know through the chat, because he doesn't have headphones, so he can't actually hear what's going on. So back to bone. The normal technique for bone, which transducer do you use? Well, typically, like with most procedures, it will be a linear transducer unless the body habitus or the location of the potential fracture is deep, in which case you'll want a higher or a lower frequency transducer. Lots of gel is good because you're putting the transducer on a potential fracture, so it's probably painful. And another technique that can be really useful with potential fractures, particularly on the hands and feet, is to use a water bath so that there's a nice step-off pad and it's much less painful, if there's any pain at all, for the patient who you're ultrasounding. So the normal appearance of bone, everybody thinks, well, you know, the sound goes in and it bounces completely off the bone and you're just going to see black behind it. And that's sometimes true, but you can also have some artifact. So you can actually have some artifact. So the sound goes in once, comes out once, great, we see the bone, but then it comes out, some of it will come out and actually go back in again, because it's reverberating between the two interfaces, the bone and the skin or the transducer. So it comes out again, except that really the ultrasound is taking into account the first time it comes out as well as the second time it goes in. So it gives you that nice artifact, the mirror artifact. So you're actually seeing the mirror of the muscle below the bone. And sometimes that will happen. It's not at all infrequent. So scanning, you're going to scan the cortex, of course, in sagittal and in the transverse plane. And that was a radial in the sagittal view, and this is the radial in the transverse view. And it's interesting to note that everybody thinks, oh, these bones are kind of flat. But in fact, if you look at the anatomy of the radius, you'll notice that it has this actual groove in it. So you'll see that on ultrasound as well. So you kind of have to know the normal anatomy of your bones as you do these scans. So I'm going to start with extremity fractures. And I actually want to talk a bit about the evidence for doing this, because a lot of times you'll say, oh, I'm going to scan the bone looking for a fracture. And people will say, well, you know, you still have to send them to X-ray. And the question is, do you? And could you use this in a remote setting where all you have is ultrasound? Say, for example, you're on a battlefield and you have an ultrasound and you're trying to decide, is this just an ankle sprain or is this a fracture? So you can actually use it in those kind of situations. So some of the evidence for using ultrasound to detect extremity fractures, I have a couple papers that we're just going to quickly talk about. So there have now been enough studies that there are meta-analyses of these. So this is from the British Medical Journal Emergency Medicine in 2009. So they looked at upper limb fracture studies and lower limb fracture studies. And they came out with, they had a number of studies going back to 2000, or actually 1998 in this case. And so they took all of the ones that were actually of high enough quality to be used in a meta-analysis. And what they found is that the sensitivity and specificity is actually pretty good. but look at the confidence intervals. So the range is highly variable, and that's something you'll have to take into account. And one of the limitations of using ultrasound for extremity fractures, both upper and lower. And so here's the same thing with the lower extremities. There's one study that had a very low sensitivity that was done in 2002, but a very high specificity. And I haven't delved enough into that study to see why it was why the conclusions were so different than the other ones. But again, a pretty good sensitivity, a pretty good specificity, but very high confidence intervals. So really a wide range. So something to think about. And then in kids, we have a review and meta-analysis of ultrasound studies on kids. And this is interesting because they included skulls, ultrasounds of skulls and nasal bones and other facial bones and clavicles and elbows and forearms and scaphoid bones and other hand bones and the feet, the metacarpals, and then long bones, foot and ankle. So they really looked at a lot of different studies. And if just looking across the board, you'll notice that actually the sensitivity and specificity for all of these was pretty good. So it is in fact feasible to use ultrasound for diagnosing fractures. And then this is just another study looking at long bone specific places. So one of the areas that they took a deeper dive into is pediatric arm fractures, and the summary, 93% sensitivity and 93% specificity. So it's not perfect. And, with a specificity of 0.93, some of those false results will be a false negative. So you're not going to catch all of the fractures, but it's pretty good. And adult ankle fractures was another one that they took a look at. And again, pretty high sensitivity and specificity. So definitely worth considering. And this is another study from the Journal of Ultrasound Medicine, where they specifically looked at hand fractures. And then interestingly, they compared ultrasound imaging and physical exam findings. And of course, the ultrasound was quite a bit better than most of the physical exam findings. It's interesting that the proportion of swelling, and I'm not sure exactly what they used, was a little bit better for your physical exam. So I guess there was a lot of swelling. It was a better predictor of a fracture than even ultrasound, just slightly. So back to our scanning of extremities. So again, we have our normal bone. And then some of the things that you'll see with a fracture is a cortical disruption, so a break in the cortex. And sometimes there is actually a periosteal lift or a hematoma. And, I've seen this cited as a reliable indicator of a fracture, but I have not always seen it when I've scanned. So sometimes it's just the cortical disruption, and sometimes you'll get the periosteal lift. And my supposition, without any hardcore evidence, is that the hematoma is probably more likely if you have slight displacement or greater displacement of the fractures than if it's just a hairline fracture and you just have a minor cortical disruption. So sometimes the fractures are pretty easy to see. But sometimes they can be quite subtle. So in this case, we have a pediatric, actually, I think this might be an adult forearm. I can't remember from looking at it, but on the left side, it looks, this is a distal radius and it looks pretty good, but you'll notice on the right side that there is simply a cortical irregularity. And again, it's great to have a contralateral normal to compare your findings to. So this is actually a little bit of a buccal fracture or just a slight, like a hairline fracture, but it's definitely different, and the patient has swelling and pain there. So I would be pretty comfortable calling that. And here's an example of a patient who has pain in the elbow, difficulty straightening out their arm. And you'll notice on the x-ray that, yeah, there's probably a little bit of a posterior fat pad there. And the x-ray was actually called normal. So we took a look with the ultrasound, and this is the radial head in the long axis view. And you can see that there's a little bit of cortical disruption right there. It's quite small. And when you look in the short axis view or the sagittal view, you can see how the cortex is nice and flat. And then right at the beginning of this video that it's very irregular, and you can actually see a hematoma there. So there's a small fracture at the radial head. So this was actually diagnosed with ultrasound and not radiology or not X-ray. So this would be something that you could definitely tell the patient that they do have a small fracture, even though it wasn't seen on the X-ray. And I would be pretty comfortable doing that, and I think I did. One of the other places that you can look for these fractures is down in the hand, so a little bit more distally. There have been some studies looking at scaphoid bones and to see actually if we can find those occult fractures. The studies to date are not entirely great, but this is definitely something to look for. And the more obvious fractures you will see on ultrasound. So the scaphoid bone has kind of these two humps to it. And of course, on your ultrasound image, proximal is to the left and distal is to the right. So on your scaphoid bone and the image, it's going to be the proximal aspect is to the right and the distal aspect is to the left. So you have a slightly larger hump, as it were, when you're looking at the more distal aspect. And it's basically scanning the anatomic snuff box. So you can look at it from the palmar aspect and the dorsal aspect to see the fractures. And this is an example. So you're actually scanning, you can see the distal end of the scaphoid with that pretty large hump, and then the trapezium. And this is the patient's right side. And you can see the cortex there looks pretty smooth. And then you can look at the left side, and you'll notice the distal hump. Or having an area here where the cortex, you can't really quite seem to line it up. And this is sort of one of the pitfalls of doing bone ultrasound. That's actually someone who has arthritis between their scaphoid and their trapezium, and it causes cortical irregularity. So one of the key things may be that there's lack of swelling. There's definitely pain there, but there's a lack of swelling, and there may, there's probably not as much tenderness. But one of the potential pitfalls is that you can have chronic changes, particularly arthritic, that have advanced to the point that the cortex is actually irregular, that could cause you to think there's a fracture. And the other thing that can be a pitfall is making sure your transducer really has to be aligned with the cortex. So particularly if you're looking at a bone with a curve, this can be something that may lead you to think that there's actually a fracture. So really, like if you're thinking about your ribs and they have a nice curve to their alignment, you'll have to really follow the cortex of the bone, and that can be tough to do. So looking at a couple other examples of fifth metacarpal, particularly distal fifth metacarpals, and the MCP joint. These are both the fifth MCP joint. So this one, you can see that there's, oops, there we go. I guess there's only one video. Okay, so you can see with this that there's a cortical disruption, and this is your sagittal view. And you can see the joint space. So that's the DIP coming into view. And you can see actually both on the dorsal and even on the volar aspect here, you can see that there's a cortical disruption. And then this is the transverse view. And again, you can see the disruption in the cortex and also a bit of a hematoma there. And just the views of the palmar with a still image, you can see that there's a break in the cortex in the MCP, or in the actually the metacarpal. So this is sort of the example of a boxer's fracture right here. So distal fifth metacarpal. And how comfortable am I saying that it's lined up well enough that it doesn't need any reduction? Well, you can kind of get that from your physical exam, and this one did not require any reduction. And you can see, let's see, you can also see that there's maybe a little bit of a sesamoid bone there. And again, this is a patient who comes in with fifth metacarpal pain, or pain when they flex their fifth finger at the MCP joint. And we take a look with ultrasound and looking at it in the sagittal plane, not a whole lot there, but then as you start to look in the transverse plane, there's this kind of strange little bone area there. And you can see, what is this? Well, that's actually this nice little foreign body, which you might be thinking, I'm not sure. And of course, it's actually a little chip of bone. So it's got an irregular cortex. It doesn't look like a nice round sesamoid bone. It's actually a little tiny avulsion fracture. This is a patient who's got knee pain, particularly they were lifting weights, and they've got knee pain, particularly anterior and right in the patellar tendon. So the thought is, oh, maybe they have a patellar tendon tear. So as we look at this first in the sagittal, and the kneecap is right here. So patella is there, and the tendon, patellar tendon going down to the tuberosity is there. And you can see that there's actually a little bit of tear just inferior to the patella. So it's nice and intact down to the down at the tuberosity, but you can see that there are actually little chips of bone torn off. So the tendon is torn, but it's actually a tiny avulsion fracture. So it's not in the middle of the tendon isn't retracted, but there's definitely a small avulsion fracture there. And you can see here, this is the short axis view, and we are progressing from inferior to superior. And again, you can see those little bone fragments and the disruption of the cortex. So this is an example. We were kind of looking for a tear, and we actually found that there's a little bit of a fracture there. So even a pretty subtle fracture you can find. And this is another patient who came in with knee pain after falling on their patella. They had some edema, very tender patella, looked a little strange. And we started to scan, and the patella is on the right side of the image. So that's inferior, and there's a large hematoma above it. And I cannot find the other video that goes with this, which shows the actual patella. So I'll have to provide you, of course, with the radiographic image. So you can see that there's actually a tear in the patella, which resulted in this very nice hematoma that you can see in the joint space. This is the toe. Well, actually, this is just an image. This is a, let's say 50-year-old female who was stepped on by a horse and has a lot of pain in the fifth toe and in the distal fifth metatarsal. So in the short axis view, this is the fifth toe, and you can see the PIP and the DIP, and then there's something in between. And if you look at it transverse, so comparing the fourth toe to the fifth toe, you can see that the middle phalanx is pretty much just all over the place and pretty well smashed. And I'll just tell you that actually the PIP joint in the end became completely fused, and the toe still does not look exactly normal. So there have been some studies looking at fracture reduction with variable results. There was, particularly in the pediatric literature, because these are the folks that we don't really want to expose to a lot of radiation. So you get the initial X-ray or you do the initial ultrasound, and the ability to predict whether these fractures needed reduction actually was in a couple of studies pretty variable. But there were two studies in AGEM recently that actually showed pretty good results for doing ultrasound guided reduction. So while you may have difficulty determining if if the fracture actually does need reduction, doing the reduction under ultrasound has been shown to be actually pretty good and equivalent to radiology in some cases. So that's a potentially great place for some additional research. So here you can see the fracture, the cortices, and then you have the reduced fracture. Oops, I went kind of through that pretty quickly, but that's demonstrating that the fracture has been reduced. You know, and if you're somewhere in an ED where you don't have a C-arm, this would actually be a great use for ultrasound. So some of the limitations of extremity ultrasound for bone is that it's less accurate near the bone ends and the joint spaces, and also the proximal femur. And I'm really not even going to get into growth plates. You can distinguish between a growth plate and a fracture, but that's definitely an area that's a little muddy. You know, there are some reports of being able to tell a fracture of the physis from a normal physis, but there's not enough evidence for me to really spend time on that. And I'd probably need to do an entire pediatric bone lecture. A body habitus can be a problem. So someone with a very large extremity, it may be difficult to get to the depth that you need to get the images. The accuracy is operator dependent. So how much training people have had and how you know, just how good they are at ultrasounding the bone makes a difference. The time availability is also an issue. So it's easy to order the ultrasound or the radiograph. It may be more difficult to spend the time to actually do the ultrasound. And then, you know, if you think it's going to need reduction, and these are usually pretty obvious fractures, you may not be able to determine that with ultrasound. And the other thing is patient comfort. There was actually one study that looked at this as part of its variables and found that ultrasound with a nice thick gel cushion was no worse than actually getting radiology imaging, so a plain film. So many people are using this for a hematoma block, so you can do an ultrasound guided procedure. And like most procedures that we do blind, it's probably better to do it with the ultrasound. So you're not palpating for those bone ends, but you're actually just looking for them. And this was actually a small study done by Michael Gottlieb. And they basically looked at using ultrasound guided hematoma blocks, and they found that this was pretty good. There's really not a lot of studies out there, but like any procedure we do blind, if we can do it blind, we can probably do it better with ultrasound. So I would encourage you to look into that and try it out. I've actually found it pretty useful. So pediatric skull fractures is another area that there's been a lot of interest in. You know, do we need a head CT to diagnose a pediatric fracture? And most of the time, you know, people will say, well, we need the head CT to look for the underlying trauma. But some folks are using this, you know, as difficult delivery. They come out of the birth canal, and do they have a skull fracture? Because they might get a very large hematoma. So it might be nice to know that in advance. So the evidence is reasonable, sensitivity of 88%. And again, this is very small. Most of these bone ultrasound studies are still pretty small. So only 69 patients and 17 clinicians. So they each performed a very limited number. So you'll notice that the range of the confidence interval for the specificity and actually for the sensitivity is quite large, and it's a little bit better for the specificity. And the specificity is actually pretty good, because that would mean that most of your true negatives are negative results, and there aren't as many false positives or false negatives, which would be a big problem. And another ultrasound of this systematic review in Emergency Medicine Journal of 2022. Basically, they looked at 7 studies that had adequate data and adequate technique with a total N of 925, had a sensitivity of 91% and a specificity of 96%. So a pretty good negative predictive value. So, and, you know, skull fractures, again, you have to make sure you're following that cortex, and you can see a nice little cortical disruption. Interestingly, I don't see that periosteal lift there, but nice cortical disruption. And this was actually a kid who came in, bonked his forehead, fell on a glass table, and he had a really sizable bump there. And I had just been looking at diagnosing pediatric skull fractures with ultrasound, and you know, he didn't have a remarkable fracture, but you can actually see that the skull table is fractured there. So it was diagnostic, and of course he had no underlying injury with that. Another area that's been looked at is facial fractures. So we can scan the bones of the face. So there's been some interest in this in ENT. And you'll notice that the studies, there's one in the Journal of Ultrasound Medicine in 2009, and then a couple of studies in ENT journals. So looking at the nasal bones in particular, and the maxilla and the zygoma. So to scan these, you might need a hockey stick transducer, so still high frequency, but it's got a smaller footprint, so you can place it right on the bones of interest. So the nasal bone, and again, you have to think about this in reverse, because on the ultrasound image, this is actually proximal and this is distal, so you're getting into the nasal cartilage at the distal aspect of it. And then looking at the nasal bones from either side as well, so you can see anterior and then the two lateral nasal bones. You can also look at the maxilla. And this again is in the sagittal view. And going down the axilla or the maxilla, you can see, you almost don't see this little tiny fracture, but here you do see that periosteal lift. It's a little better seen. So this is actually going from superior to inferior with the transducer in the transverse orientation. And we actually get a little bit of a step off where that fracture is. Another area is looking at the thorax. So rib fractures, sternal fractures, folks have been looking at. So the evidence for this is that we may be better at doing plain films. So this was a study in 2010. It looked at 20 patients who had a normal chest X-ray, and then they found 26 rib fractures total by ultrasound. Unfortunately, there was no gold standard. So these patients didn't get a CT. So we don't actually know the sensitivity and specificity because we have no gold standard. So I don't know if those rib fractures were true positives. I don't know. And then there was another study in 2020 in GEM that looked at rib fracture diagnosis in blunt thoracic trauma. But they basically scanned sort of every rib trying to find if there are fractures. So the results from this were not so good because they weren't really going by point tenderness or like a specific rib fracture. And some of the issues with scanning the ribs and the thorax are that not the entirety of the ribs is bony. So there's a lot of cartilage there. And if you look particularly in the lower ribs, there's a huge amount of cartilage. And all of the ribs have this junction between the cartilaginous portion of the rib and the bony portion of the rib. And there's a couple, there's a junction here between the rib, the bony cartilage, I'm gonna trip all over myself, the cartilaginous portion and the bony portion. And then there's also joints between the sternum and the rib. So those can potentially be a false negative, or sorry, a false positive when you're scanning. And if you're doing the sternum, you really have to look at the entire sternum and not detect the sternocleidomanubrial junction as a fracture. So example of rib fractures, and this one is really, it's kind of blown up, so it's a little bit fuzzy, but you can see that cortical disruption and a little bit of that hematoma as well. Another example, here you have a pretty good cortical disruption and that hematoma. One of the issues with scanning the thorax and the ribs is that there's lung underneath. So in this image, we are looking at it in the sagittal view, And so people are thinking, oh, well, this is the rib, but actually that's not the rib. The rib is cartilaginous, so we're still in the cartilaginous portion. And this is actually the lung underneath the rib. So you want to make sure that you're not seeing lung and thinking this is a hematoma, where it's actually the rib itself. So as you're looking, and this is the bony part of the rib, and you can actually see the lung sliding underneath. So you want to make sure that you can actually see both of those things, lung sliding and the rib, to make sure that you are not in the wrong place. And you can also think of the fascial plane as a rib. So if you can see the rib and the lung underneath it, you know you're in the right place. So potential pitfalls, the sternocostal joints and the sternal-manubrial joint. And then you can also mistake the pectoralis muscle for a hematoma in short axis. I haven't actually looked at this, but there a couple times this is cited in the literature. And another pitfall is mistaking the pleural line or flat fascial plane for the rib in thoracic scanning. So look for the lungs sliding to find the rib. And of course, if you have a pneumothorax, there won't be lung sliding, but there will be another bright white line below the rib. And if it's in the bony portion, you'll have that gap where the rib is shadowing. And remember the contour of the ribs, they're curved, and that the cartilaginous areas of the ribs will be less echogenic. So overall, some of the limitations of bone ultrasound. Body habitus is a big one. It's operator dependent. So the training and experience of the person doing the ultrasound really does make a difference. And then the element of time. So if you're looking for a bunch of rib fractures, if the entire left side of the thorax is tender, that is going to take quite a bit of time to look for those rib fractures, and maybe not something I'm really going to be able to do. The fracture location may be a limitation. Patient comfort, not sure about that one. And then your consultant requirements. So you're going to do an ultrasound and take 15 minutes, and then your consultant doesn't care and they require an X-ray. So in that case, do I really want to spend the time doing the ultrasound? So in austere environments, though, I think this is a great tool. And I think if you're in a really busy ED and somebody comes in with a painful toe and they want to know if it's fractured, that ultrasound is a great tool. And since you're going to buddy tape it anyway, you can let them know it's fractured simply by taking a look with the ultrasound. And probably finger fractures, you can do this with as well. And then if they're not significantly displaced, you can place a splint. Some other potential diagnostic uses: occult fractures, like stress fractures. There's some studies looking at, can we see those better? And also the occult scaphoid fractures. How do we do with ultrasound compared to MRI on those types of fractures? And then infection. Dr. Boswell mentioned briefly last week that you can see osteomyelitis with the ultrasound. And what I don't know and what isn't known is whether you can see it with ultrasound before you can see it on X-ray. So that's something to look at. How does ultrasound compare to MRI? And then also bony tumors. Can we look at it and diagnose and characterize those? Perhaps not in the emergency department. And who knows what some of the other uses might be. So basically, our summary, we talked about the evidence for use of ultrasound in fracture diagnosis. Most of the studies have been in the extremity. Most accuracy in using this is in the diaphysis of the bone. There's some evidence for facial fractures and thoracic fractures. And the best use for this might be in areas and times of limited resources. We talked a little bit about the appearance of the bone, the bony cortex, and how you can find a fracture. Remember, it's that cortical disruption and looking for that periosteal lift, the hematoma, and potentially the soft tissue swelling around it. And remember that bone ultrasound is fairly limited by the body habitus, by the operator, whoever is scanning, the time, the fracture location, and potentially patient comfort as well.